Hi, it's Bree Smith, SN, here to help you succeed in nursing school and on the NCLEX.
These videos will be general reviews that harp on the major points you should know for these drugs, not so much the nitty-gritty details. So make sure to use this in addition to your primary academic resources, not as your only source of information. In this video, we are covering a wide variety of neuro drugs, so check the chapters and timestamps to help you find specific ones you are wanting to focus on. Let's begin. First is sedative and hypnotic drugs, used to sedate or put to sleep our patients. We will be focusing on benzodiazepines first, with the prototype drugs temazepam and lorazepam. Our benzos here end in PAM, so think of a sleepy woman named Pam who is given benzos. These drugs work by enhancing GABA, the major inhibitory neurotransmitter in our central nervous system. When our systems are inhibited, we see the patient exhibit decreased central stimulation. These are used in the treatment of seizures, insomnia, alcohol withdrawal, and severe anxiety. Due to their addictive nature, they should only be used for a short duration, and the dose should be tapered, or else our patient may exhibit rebound hyperstimulation. Since we are sedating our patients, too much of these drugs can lead to adverse effects of respiratory depression and altered level of consciousness. Our priority nursing assessment is to monitor respiratory status and level of consciousness. If we suspect an overdose, the antidote for benzodiazepine medications is flumazenil. Patient education. Do not combine with other CNS depressants, including alcohol. Do not operate heavy machinery. Take this medication before bed, and if you must change positions, make sure to do so slowly. Do not discontinue suddenly, but taper the dose according to provider instructions. For a non-benzodiazepine sedative hypnotic, we have zolpidem. This drug has less addictive potential, but has similar adverse effects such as excessive sedation, somnolence, confusion, and also anterograde amnesia, where the patient may engage in activities while on this medication that they will not remember once its effects wear off. Let's discuss a few muscle relaxants next. First up is baclofen, a centrally acting muscle relaxant. Remember that it is centrally acting by connecting back with your back, aka your spinal cord and CNS. GABA, the major inhibitory neurotransmitter, is increased and smooth muscle spasticity is reduced with this medication. Since smooth muscles are being slowed down, your side effects correlate. GI motility is slowed, leading to effects such as nausea and constipation. Patient teaching includes increasing fiber and fluids to combat these GI effects. Do not discontinue suddenly or else rebound withdrawal symptoms may occur. Next, we have dantrolene, a peripherally acting muscle relaxant, which works by preventing calcium release and therefore slowing action potential generation, which causes skeletal muscle contractions. To remember this, think of Dan, the dancing yellow man. He is moving his skeletal peripheral limbs while dancing and is yellow due to an adverse effect that we will explore in a moment. Dantrolene may lead to hepatotoxicity, so the patient's liver function should be monitored during therapy. Additionally, assess for indications of hepatic injury, such as jaundice. Assess the patient for excessive muscle flaccidity that may increase their risk for falls. Dantrolene sodium is the treatment for a condition called malignant hyperthermia, which we will mention later in this video. To remember this, think that Dan hates hot milk. Dantrolene fights hot, malignant hyperthermia, and the milk part can help you remember that dantrolene is a calcium channel blocker. Let's turn our attention towards our AEDs. First is phenytoin. Major points for this drug include its narrow therapeutic range of 10 to 20 micrograms per milliliter. Make sure serum levels are checked before administering the patient's dose. Other things to watch for with this medication is the Stevens-Johnson's rash, a severe epidermal necrotic reaction that can be life-threatening. While AEDs should not be stopped suddenly for risk of rebound withdrawal effects, if the patient is in danger, then do not administer the dose and report to a provider immediately. On a less severe note, patient education should include diligent oral care to prevent or treat gingival hyperplasia that may occur with this drug. Females on oral contraceptives should incorporate barrier methods of birth control, as AEDs interfere with the effectivity of PO contraception. Another AED of note is carbamazepine. Major points here is that the drug can lead to bone marrow suppression, which can manifest as pancytopenia. This places the patient at increased risk for anemia, excessive bleeding, and severe infections. CBCs should be monitored regularly for patients on this drug. Valproic acid is an AED that may also be indicated for the treatment of bipolar mania and migraines. Patient teaching should emphasize that females of childbearing age should supplement folic acid, as valproic acid may interfere with the bioavailability of folate and increase the risk for neural tube defects in the fetus. On to anesthetics. First is lidocaine, which we will use for local interference with pain transmission. An example use for lidocaine in its topical form is Emla-cream, which we can use as part of atraumatic care for pediatric patients by applying to the site of a venipuncture about an hour before the procedure. If absorbed systemically, lidocaine has side and adverse effects of hypotension and cardiac dysrhythmias. Barbiturates such as thiopental may be used in the OR, and like benzos, act to increase GABA and lead to sedation. Also similar to benzos, the reactions to watch for here are oversedation and respiratory depression. These drugs are highly vesicant, and so care should be taken to ensure the IV site is patent and that there are no indications of infiltration. A large vein should be used. Fentanyl is an opioid analgesic, and being a narcotic, places the patient at risk for oversedation and respiratory depression. The priority assessment for patients on fentanyl should be respiratory status and level of consciousness. If overdose is suspected, the antidote naloxone should be administered promptly. Diminished GI motility and subsequent constipation is a common side effect of opioid use. Unlike other potential side effects, such as nausea and itching, constipation will not resolve with time. Therefore, patient education should include increasing fiber and fluids and utilizing stool softeners if needed. Our last anesthetic to cover is the neuromuscular blocking agent succinylcholine, which is given adjunct to surgery and during intubations. However, a genetic predisposition to a condition called malignant hyperthermia may present when this drug is administered. This leads to severe temperature elevation and muscle rigidity in afflicted patients and is treated with dantrolene sodium, as mentioned previously within this video. We will now cover the stimulant medications, amphetamine and methylphenidate. These drugs treat ADHD as well as narcolepsy by increasing norepinephrine and dopamine availability. These drugs confer stimulant effects, which may lead to tachycardia and restlessness for the patient. Tachycardia may be expected as a side effect, but should be monitored if accompanied by symptoms which indicate impaired cardiac output. Patient education should emphasize this, as well as the importance of avoiding other stimulants such as caffeine. Patient education should also address nutrition and growth, especially for pediatric patients. Stimulants suppress appetite and should be taken early in the day to prevent insomnia and with or just before or after a large breakfast to compensate for the dulled appetite that will develop as the drug takes effect. Pediatric patients are advised to take drug holidays in order to encourage adequate growth and prevent dependence and tolerance. In the treatment of neurocognitive disorders, there are a few drugs used in the treatment of Parkinson's that we will review now. First is levodopa-carbidopa, which together increase the availability of dopamine to decrease tremors and muscle rigidity. Adverse events related to the increased dopamine manifest as CNS disturbances such as hallucinations and psychosis, cardiac effects such as dysrhythmias, and motor abnormalities such as dyskinesias and tics. Patient teaching should relate to correct administration. High-protein meals diminish the absorption of this drug, and so patients should be instructed to space out protein intake throughout the day and avoid eating large amounts of protein at once and around the time of administration. Benztropine is an anticholinergic drug which is used in symptom management. By acting as an antagonist for acetylcholine, tremors and muscle rigidity may be reduced. The patient may also find relief from excessive drooling due to the anticholinergic side effects. Can't see, can't pee, can't spit, can't shh. Whenever an anticholinergic is involved, expect these side effects. Patient teaching relates to these as the patient may be recommended to increase fluid and fiber intake, chew sugarless gum, and use eye lubricating drops to minimize discomfort. On to drugs used in the management of Alzheimer's. While not a cure for Alzheimer's, the drug donepezil is used to increase acetylcholine availability and reduce symptoms associated with this neurodegenerative disease. The drug works by inhibiting the breakdown of acetylcholine by the enzyme cholinesterase. More acetylcholine available can contribute to increased SNS stimulation, leading to potential adverse reactions of bradycardia and syncope, insomnia, and excessive GI motility. The last drug to be covered today is sumatriptan, which is used in the treatment of migraines. The therapeutic effect is conferred by vasoconstriction and slowing pain transmission, as well as the release of hormones which contribute to the symptoms associated with migraines. Since vasoconstriction is occurring, our side effect to watch out for relates to vasoconstriction elsewhere in the body. Some angina is expected, but be sure to assess the patient for coronary vasospasm or other indications of compromised cardiac output. Thank you for watching this quick and dirty review of neuro drugs. While this is far from a comprehensive breakdown, the most commonly emphasized points on the NCLEX and in clinical practice are covered here. Please make sure to utilize your assigned textbooks and modules in addition to this review.
Remember to keep studying and keep working hard.